right, let's see. Okay, everybody can hear me. Audio is really low. Can you hear me now, Bonnie? Let's see. Hopefully you can hear me. Okay. All right, this is working. Okay. So I'm going to get really up close and personal. Oh, we got hands raised here. This is going to be great. It is Heart Health Month. It's official. It is Heart Health Month. So, and it's fasting February. Super, super excited. If you're not on our app, if you're just joining us from who knows where, get our app, guys. Get our app. And we have a free fasting group this whole month. If you want a medical lecture on fasting, it's going to be the third week of that fasting group. If you're looking for a fasting support group, just go straight to that fasting group. You can find it through the website, through our courses. If you're on the app, you can find it at the top in the events, the registration. You just sign up for it, and then you can come. You can come. So let's just do a couple of things here just to get things all set up. I want to make sure I'm going to bring up my PowerPoint here, and then we will be set to go. Okay. All right. So I need to get a quick thumbs up if you all, you know what? I'm going to put this on a different screen so that I can make sure everybody can see this. Okay. I'm going to show you some cool stuff today, guys. I got to be honest. It's really, really cool stuff. I think it's cool, but I'm a nerd, so hopefully you guys can nerd out with me. We're going to be talking about cardiovascular disease. I'm actually going to start by showing you guys the most kind of what I think the coolest test in cardiovascular screening. It's called a CCTA. It's called it's a cardiac CT angiogram. And we're going to actually start off by looking at a cardiac CT angiogram, which I think is pretty darn cool. Okay, so let me get this set up. And all right, share my screen. And give me like a big thumbs up if you all could see my screen, because yes, okay, thumbs up, perfect. Okay, you can see me? Can you guys see me? See if we can look at the right place. All right. All right, you all can see me and you can see the screen, so we're ready to go. Okay. All right, so February is Heart Health Month. Every month in our practice, which we've renamed, it's called Toward Health now, Toward.health. And the reason for that name change is super, super easy. There's a lot more clinicians coming on. We have a ton of health coaches. It's a team. So super excited about that name change. And pay attention, guys. We have a huge paper going to be released very soon. But one of the things we've done here is every month we want to have something free, something interactive, and something kind of special. So this month there's actually two things. There's this cardiovascular lecture, and there's going to be a fasting group. So hop onto the website and check out the fasting group. And today we're going to be talking about cardiovascular disease, and hopefully you guys can see this video. Can you guys see this video? Give me a thumbs up. You could see something rotating down here. I'm going to pause it and I'm going to explain it. So what you guys are actually looking at here is a really cool thing, and this is hard to understand what you're looking at, but I'm going to explain it to you. So these are multiple different views of the heart, and you can disregard everything for now for 1 second. You can, do you guys see the screen? Do you guys see a screen here? Somebody tell me if you see it. Do you see like a weird 3D thing flying around at the bottom? Yes. Okay, good. Okay. Yes. Weird 3D thing. Okay, perfect. So what this weird 3D thing here at the bottom is, it's actually a reconstruction using AI of the 3 blood vessels going to your heart. So when you have a heart attack, it's actually a blockage in one of these blood vessels. And these blood vessels aren't really all that big. We're talking about a couple of millimeters big, okay? A couple of millimeters big. So what you're looking at here is a sort of a composite view using a CAT scan and using a little bit of dye that goes into the heart arteries. And we're able to use AI and analyzing that CAT scan in several different dimensions to create a 3D model. And this is called a CCTA. So I get this 3D model and I could sort of spin it around, look at your heart, look at the three main blood vessels that feed your heart, and I can zoom in and zoom out and see not only is there calcium, but is there soft plaque. And you'll see up here where, you know, we're kind of going up and down. This is a 3D enhanced or 3D sort of AI enhanced like transgression basically through the heart. So it's cutting, you know, you could see there's it's guiding you on where we are in the heart based on this red oval. And that red oval is then brought up here into a slice. And that's showing us exactly what's going on in that artery. And you're going to see here now, there's a bit of calcium. You'll see it in a bit, and I'll pause when that happens. So we're coming up right here on the artery, and you can see that there's a bit of calcium here in the artery. And so what is this telling me? This heart test, you know, it's telling me how obstructive that calcified plaque is. It also lets me know if there's plaque that's not obstructive, that's not calcified. So a CAC will only show the calcium, but this test will also show obstructions that are not calcium. And you can see there's some calcium here at the tip of the artery as it comes out of the aorta. And that aorta is the big artery that comes out of the heart. And the first branches of that artery are the coronary arteries, the first place to get blood. When those valves close on that big aorta coming out of your heart, the blood vessels, the coronary arteries fill up in that relaxation phase. So can you guys all see this? There's a couple people who said no, they can't see this. So give me like a yes or no. Give me a thumbs up if you can see that. Okay, so a lot of people saying they could see it. So, okay, I'm sorry if you can't. This will be saved on live stream, so I should be able to find it and give it to you if you can't see it. But so this is a 3D, you know, sort of you know, an AI enhanced 3D, you know, CCTA, cardiac CTA, which stands for CT angiogram. And it's like a CAC with a little bit more radiation, a little bit of dye, and it's able to look at your heart in 3D. And the beautiful thing about this is it can tell you if there's a calcified area, but it can also tell you if there's some obstruction that maybe is not calcified yet. So it's a new plaque could be seen there. So this is really cool. We do these tests. The question you may ask is, when should I do this test, right? When should I do this test? And really, it's kind of really rare. If you are a low risk patient, if you're generally healthy, maybe you have a 0 CAC and you have some chest pain, you could consider this. If you, so atypical chest pain, a cardiac CTA may be appropriate test. If there's a little bit of calcium and you want to understand if there's more or different types of plaque, this may be also an appropriate test. But in general, you know, from my perspective, this test has drawbacks. It comes with some extra radiation, which a CAC doesn't. CAC is a very low risk test. So this is a bit of new information you may have not seen before. This is called a CCTA. This happens to be the one we like, which is an AI-enhanced CCTA. And I'd imagine that, a lot of ER guidelines are now recommending CCTAs to instead of sort of holding people in the hospital and getting them a stress test as a quicker and easier way to evaluate somebody's heart. So it's a really cool test. Hopefully you guys find it as cool as I do, and you guys can all geek out with me. So let's go back. I wanted to give you all the cool stuff up front, and we got some hands raised. So you guys, if there's any questions, just put it into the chat or put it in the Q&A. I think we have a Q&A somewhere. So I promise I'll get to it periodically. So if you could just put your hands down. I mean, you could leave it up, but absolutely, you can write in your questions if you have it. So we already got a couple questions, which I'll get to before we go on. One, is it really expensive? It is expensive. It is often covered by insurance. Medicare covers it now, and many commercial insurances cover it in the right condition, in the right setting. It's not really used for just screening. It's more used for the workup of chest pain. Nice to have you back, Richard, from Jamaica. We're so happy to see you back, brother. Keep coming back. Here's a great question is, are they available throughout the US? Absolutely. Yes, you do need a referral from a physician. This particular test that you saw was clearly another example is HeartFlow. We use both of them. It is very similar to that test. Absolutely. We got another question here from Michael. Is it appropriate for those with existing stents? It depends. You could use it to look at the other blood vessels, but it would not be great to look at the stents make it hard to see exactly what's going on through it. If you were concerned about that stent clogging up, it's absolutely a great test. You'd be able to see that. You'd be able to see the dye passing through those stents. So it depends. Existing stents make it a little bit of a challenge. But it could be appropriate. Okay, so let's come back. It's Heart Health Month. That's the coolest, newest heart health. This is like, I feel like I'm a dad giving their kids, dessert before the dinner. But that's all right. I gave you the cool stuff up front. Hopefully the meat and the vegetables are still okay. I know we all like meat and vegetables here. Give me a thumbs up if we like the meat and vegetables. All right. Somebody laughed at my terrible joke. Okay. So cardiovascular disease, it's not one thing, right? Basically, let me boil it down. We're talking about the plumbing. We're talking about damaged piping, and we're talking about those piping getting stiffer and more clogged over time. And don't make it more complicated. Don't let doctors make this more complicated than it has to be. This is not complicated. Cardiovascular disease is glorified plumbing, right? These are pipes. The pipes get damaged. The pipes have clogs, right? That's essentially what it is. I think we make it more complicated than it is. When it's in the legs, we call it peripheral vascular disease. When it's in the heart, we call it coronary artery disease. When it's in the carotids, we call it carotid disease. And there's some disagreements about the pathology, right? There's some disagreements about how this exactly happens. And this is, my belief. I think most people would probably agree with this, even conventional medicine. You get obesity, you get metabolic syndrome, right? You get high triglycerides, high HDL, high blood sugar, high blood pressure. All of these things put damage or put pressure on the piping, on our blood vessels. The blood sugars glycate, right, cause damage to the glycocalyx, the peripheral part of that artery, and so does smoking, so does heavy metals, so do microplastics, so do a lot of different things, autoimmune disease. But the predominant thing in the majority of our population is certainly blood sugar and metabolic syndrome and the resulting insulin resistance and high blood pressure. Basically, this causes damage. the body seeks to repair that damage, right? And in that repair, basically creates plaques that eventually become calcified. And those plaques are a combination of inflammation, cholesterol, and other things. They've even found microplastics in these clots. So this is, in a nutshell, cardiovascular disease. It's the number 1 cause of death in men and women. Okay, over 25% of people die from heart disease. There's 1 death every 36 seconds, which means in the 10 minutes that we've been here, or 15 minutes that we've been here, just imagine 20 or 30 or people have died or more. And there's some words you should know around this. So atherosclerosis is a fancy way of saying, developing this atheromatous plaque. It's a multi-year process developing these plaques. It doesn't happen all at once. It can happen all at once under the right scenario. So I'll give you examples of clots that can happen instantaneously. So cocaine is an example of an agent that not only thickens the blood, but also spazzes the artery and causes it to close and become real narrow. And it can clot really quickly. Heavy lead exposure can thicken the blood, or heavy metal exposure can thicken the blood acutely and do things. But for the most part in our population, when we're talking about atherosclerotic cardiovascular disease, we're talking about blood sugar and inflammation over decades leading to essentially clogging of the arteries. So with the result being those narrowed arteries, the result being narrowed arteries and rigid sort of blood vessels. So one thing I want to note here, you have to be very careful with a high CAC score, because when you have a high CAC score, you have to understand it makes it harder to see through, right, the dye. It makes it hard to see the dye really through the high calcium. So just an FYI, if you have a high calcium score, the utility of the CCTA goes down. So I see that comment in here. That's a good question. It depends on how you define high. So some people would argue under 1,000 may be difficult, but you may just want to answer simply the question, is dye getting through, right? And with a high CAC score, remember, if that whole artery is calcified, you're not going to be able to see the dye go through, right? So just something, to think about, and we could talk more about. So what is the natural progression of atherosclerosis? Again, this is the end stage. This is a heart attack. This is damage to the heart, the muscle tissue of the heart, right? So this is important to know. Like, this is what we're trying to prevent. And in some cases, this can happen instantaneously. Like I said, if you're doing cocaine and spending many sleepless nights, as you inhale cadmium, from the pea proteins and the chocolate, right? If you're inhaling the cadmium powder and all the lead that's in it, right? The cadmium, you're going to get clogging of the artery. But for the most part, what we're concerned about is the slow deterioration of the piping over time and narrowing, which makes you more at risk for a clot to form. So this is, what we consider the natural progression of atherosclerosis. There are acute things, like I mentioned, that can cause it. The other acute thing that can cause this is autoimmune disease. Autoimmune disease can cause acute inflammation of the arterial wall and acute sort of clot formation. So can you still have a heart attack with a 0 CAC score? Absolutely. If you have an autoimmune flare in your coronary artery, as you are sleepless for several days while you do cocaine and inhale cadmium, I suggest that you have your cardiologist and your or your plumber easily available to talk to you. So, so this is me being cheeky. If you guys don't get the humor or it's too dry, just somebody put a frowny face. I don't know if they got a frowny face, but if my humor is like really too dry for you all, just let me know, because I do not recommend anybody. Beth, don't do cocaine as you inhale cadmium, okay, while you're sleepless for nights. So that is not a suggestion. But if you happen to do it, we would be concerned that you may develop a clot in there, you know, even with a 0 CAC score. But the idea is, how do we prevent the damage? And you know, the structure of the plaques, we know what these plaques look like over time. We know earlier plaques are basically not calcified, and they're sort of fibrous or really fatty. These plaques can actually regress and reverse, believe it or not. So fibroflatty plaques, you know, that are not yet calcified can regress. And so just to keep that in mind, as your body is like looking to sort of stabilize this process, it appears, the idea is that it's going to become more calcified. Why do we think that calcified plaques are part of the repair process? Because dense plaques tend not to cause acute heart attacks. Dense plaques are associated with exercise, which seem to be protective of cardiac events, and seemingly, you know, the statin medications tend to stabilize these plaques, and, well, shouldn't say stabilize these plaques, they make it more calcified. So they make the plaques more calcified. That's I think the most likely explanation of how they work, although it's not completely clear. This is what plaques kind of look like when we take them out. They can be very rubbery, and you know, they're sort of spongy. They feel like maybe like a gummy worm. I know nobody here has had gummy worms lately, but this is sort of what it looks and feels like. And here is an angiogram. So this is very similar to that CCTA that you saw, but it's a lot more dye and it's a lot more sensitive. And you could see here in the picture here, it's tough to imagine, but you could kind of see the spine here, and you could kind of see there's these arteries originating from here, right? So the aorta is probably hanging out somewhere here, and there's a small little catheter that's here injecting dye, and it's showing the coronary arteries. And you can see there's a lot of coronary arteries. You have to imagine this is 2D, you're looking at it, but it's really representing something in 3D, like we were looking at earlier. And you can see right here, the dye comes here, and it stops. Right? So now imagine you are looking at a lucency on a CAT scan due to a calcified artery, and that calcified artery, right, you'd see the dye, which is also lights up in the same way. You may not see it appropriately if you had a lot of calcium. So just be careful if you have a high calcium score and you're going for a CCTA. It may not be the best bet. You may want to just go for the angiogram and save your time and money. So here is that artery after the stents. Can you guys all see that? So like, I'm going to go back one here. You could see no blood going through that blocked artery. And then you could see here sort of blood going through that artery because it's been opened up with a stent, which you could see was delivered, you know, basically between here and here. So that is an angiogram. So, you know, I'm going to pause here, and I see there's some questions before I get into the sort of the clinical signs. This is a great question. So there's so many questions here that I want to answer. So I'm going to start with Shelley. She says, should everyone have a regular CAC, or is it that only if you have risk factors. Okay, so I believe that if you have risk factors, you should get a CAC earlier. This is Tro's belief. This is not the, guideline, right? The guideline would say only if the risk is uncertain should you proceed with the CAC, right? My belief is that every man at the age of 45 and every woman at the age of 50 should have a CAC. And if they have a family history, they may want to get it 5 years sooner. And I like the cadence of every 3 to 5 years, depending on their risk factors. So I think that it's a very reasonable test to get because it can let you know things maybe 10 years before they happen. So I see very little downside to the test. It's got the radiation of 2 flights, and we'll go into that. Can you reverse your CAC to 0? Will, this is a great question. I have seen it reverse, but I'm going to tell you I don't believe my eyes, and maybe I'm going to see if I can draw on here and yeah, let me see if I can draw on here. Okay, so I've seen it reverse. Oh my, where's my thing here? Okay, so imagine there's an artery. You guys see me drawing here? You guys see me drawing? Give me like a thumbs up. Give me thumbs up if you see me drawing. Okay, good. So pretend this is that area of calcium in an artery, Will. And so now you're like, well, can I go to 0, right? Depending on the score. And I've seen this, right? I've seen it like 1 year we get a scan and the scanner is going like this, right? And the score is like 20, right? In that artery, right? So, and then, right? And then, you get another year and you like happen to go here and it's like, what? Wait a second, my score is now 0, right? So this is, you got to be careful with the CAC. Remember, they're like 2.5 millimeter cuts. So you're not always you can't 100% rely on it going to 0. So, but let me tell you what I have seen in my clinic. I have seen people's score go down. I've seen people over multiple years, 5 years, 7 years. I've seen people's score go down. I've seen people's plaques regress on serial CCTAs. So, and we'll talk about in the app, we have a whole, oh geez, hold on 1 second. Just 1 second, guys. My wife says accident, so I got a call. I'm so sorry. Give me 1 minute. Give me 1 minute. Let me make sure she's okay. Okay. She said accident, but she just butt dialed me apparently. So that was the accident. So all right, guys. So I'm back. Okay, I'm back. So Will, to answer your question, in the app, there's an area for coronary artery calcification. Laura, myself, and some others, Matt Calkins was also helpful. We went and we looked through everything that reduces plaques. I mean, we'll start with supplements, vitamin K2, nattokinase, right? We've looked in, if you have endothelial dysfunction, maybe vitamin C. These are theoretic benefits. Nattokinase has been shown to reduce carotid plaques. K2 has been shown to halt plaque progression and even regress some plaque. Then once you go into medications, a number of medications have been shown to reverse or at least reverse soft plaques. Calcified plaques, there's a question of Vasipa doing that. There's a question of the injection drugs doing that. There's some case reports on colchicine doing that, but I'm not recommending any of these. All of these have side effects, and there's a risk benefit for each one of these. So, but I think the app does a good job of summarizing what's out there for reversing the CAC. And I think, right now, if you ask Dr. Agustin from Miami, the author of the South Beach Diet, who CACs are basically named after, Agatston score, he says you should expect a 20% to 30% progression in calcium per year. So in fact, if you have a slower progression than that, if your progression is, 10 or 15%, your risk is actually very low of having a cardiac event. So just something to keep in mind, right? Just having something to keep in mind. Okay, so I'm going to go on now. I think I answered all the questions here. Are there blood tests that correlate with the amount of soft plaque? I think the best test, Luis, is a carotid and femoral ultrasound. You'll be able to see soft plaque. And then in terms of blood tests, I think the most correlative is probably an LPIR score with an NMR blood test. And after that, I mean, there's LPPLA2, which I think correlates, with the presence of plaque. But I think those are the LPIR. That would be probably the best one. Okay, I'm going to go on. So what does it feel like to have, what are the clinical signs of atherosclerosis? And a lot of you know this, and this disease develops and it's silent over a lot of years, right? We all sort of got the crappy advice to, give me like a thumbs up or something if you were told. We should do a thumbs down, really, but if you did the heart healthy vegetable oil and the heart healthy Cheerios and the heart healthy, Pop-Tart, the whole grain Pop-Tarts, right? So we were all kind of like, this is why it's silent, because we've been poisoning ourselves for decades with faulty nutritional advice and really faulty lifestyle advice. Now, microplastics and, it's really tough to be healthy in our modern world. So it's silent. And, when it gets to a critical mass, that's when you symptoms develop. That's like a TIA where you get a stroke-like symptoms that may resolve, or you get chest pain that sort of resolves, or, shortness of breath or dyspnea on exertion. The end stage is basically complete cloggage in the brain, which would be a stroke, and a complete clog in the heart arteries, which would be a heart attack. So those would be the end stage. Certainly, you want to know what those signs are and get there before it gets to that stage. But it's like a slowly developing thing. That's why the CAC is so important. And you've all probably seen me post this on social media. But this is, if you look at what are the things that predict future heart disease, and this is in women, but you really can extrapolate it to men as well. This is just in the Women's Health Study that they got this from, or the Nurses' Health Study. And you can see that diabetes is the most potent predictor of heart disease. You can see metabolic syndrome, smoking, obesity, and hypertension. They're very predictive of developing heart disease. And then, people ask me about cholesterol. Well, do they matter? Yeah, they matter, but it's kind of like they matter minimally compared to these, right? I mean, like, these are the big things. And the problem is doctors don't pay attention to this because, these are affected through lifestyle. These are changed through lifestyle. And doctors have historically been really terrible at inspiring or helping with lifestyle change. So they've ended up focusing on things that could change, which are LDL cholesterol, which it seems like, some mildly predicts heart disease. And some of the data suggests that cholesterol is linearly related with cardiovascular disease, but I think it's more complicated than it's been presented. So, what are the things you can control if you have heart disease or you're looking to prevent heart disease? I mean, physical activity, you can control that. Go back and look, if you're physically active, that matters just as much, as cholesterol does, right? So physical activity, walks, resistance training, controlling your stress, meditation, getting good rest, sleep, quitting tobacco if you use it, and the rest of these, diabetes, hypertension, obesity, metabolic syndrome, these are largely diet driven. So, you can really, revert. A lot of this is in your power, so you can do a lot with this. And then if you look what's not in your control, you can't control your genetics or your family history. You can't control your age being the biggest risk factor. The more we age, the more the piping is hardened and the more pliable it is. So, yeah, I'm going to answer some questions here. Amy's, so nice to see you, Amy. We saw you at the conference. It's nice to see you here. super happy, excited to see you here. So can the heart disease be reversed or stopped? Yeah, we talked about that. It seems like it can be. In my practice, I have maybe 10 cases of serial CACs that have either stayed the same over a long time, meaning 5 years or more, or have decreased. So, and we are looking to publish that. It's not yet published. It's just my observation of these, select people. So we have seen that. I think there's more data coming. I've seen score in the 7,000 range that are asymptomatic, cardiac wise. So I've seen, the score be asymptomatic. So that's yeah. So just to let you know, once you get up there, right, once you're getting in the thousands, remember, it's like these minute, when you're doing that CAC, these minute, like when you're very low, it's inaccurate. When you're very high, it's inaccurate. It has to do with just the nature of the test. So, it's something to keep in mind, especially when you're thinking about that CCTA. You may want to just skip that and do the angiogram. The heart flow or the clearly would not be, I would save your money. That's what I would say. But anyway, let's go here. I'm going to keep going here. Oh yeah, I have to remind you all, I'm not a doctor here. Even if I am your doctor, text me through, text me separately, right? If I am your doctor, text me separately. So how do we diagnose cardiovascular disease, right? Everybody's like, well, how do I figure this out? Well, here are the non-invasive ways you could do it. Actually, one of the simplest way is doing a ankle brachial index, an ABI, which is a blood pressure, super low, heck, easy way to do it. Make sure there's no pressure changes in any of the arteries going down to the lower extremity. A vascular ultrasound will pick up soft plaques very early. So if you do a carotid and a femoral artery ultrasound, you must ask them, because the radiologists are so lazy, they will not comment on plaques. You must ask them to tell you if they see plaques, because they don't care unless it's 50% clogged. So you must ask them, right? You must ask them about that. So the other ways to do it is a stress test, whether it's a treadmill, EKG stress test, the nuclear stress test, which we'll briefly talk about, and we talked about the CCTA already. And the invasive way of testing it is, an angiogram, which I showed you pictures of, which would be the most accurate way to diagnose it. And so what is a treadmill stress test, right? I'm going to just explain it to you so you guys know. It's basically saying, it's asking the question, can I get blood flow through areas of the heart? And we put leads all around the heart, and then we stress with you, we make your heart need more oxygen, and we're looking to see if blood can go through and deliver oxygen. If it can't, one of the leads will actually show us, hey, there's a bit of strain that develops, right? There's a bit of strain that develops on the EKG. So, a positive stress test would be greater than 1 millimeter, so 2 millimeters in 2 consecutive leads. That would be a confirmed positive. If it's 1 millimeter in 1 lead, that's kind of like not really positive, but you may want to look deeper in that case. So, and if you have, again, this is a functional test, right? It's making you need more oxygen, and we're seeing if you can get blood flow through an area that's potentially clogged, right? A nuclear stress test, which, is a little bit more accurate, same concept. We're looking to see if nuclear material can go through that heart and light up on a scanner. And what happens here is we would see in a normal tissue, we'd see blood flow deliver the nuclear material all throughout the heart, and we'd be able to see that lighting up. And if there was an area that was blocked off, you'd see there would be an area that's sort of missing, and that would imply, there's a problem, there's a blockage that we need to deal with. Well, let's talk about calcium scores, and I think there's some excellent questions here about what's the difference between a score and the density of that score. In fact, score is now broken up into a density score and the total score, which is the volume, and it takes the volume and the density into account. So, which means that when you are reading a score, there's a volume component and a density component, and the density component is measured in Hounsfield units. And if the volume is going down, right, and the density is going up, right, that's not necessarily a bad thing, right? That's not necessarily a bad thing, right? That means that those plaques are shrinking and calcifying. So hopefully that answers Doris's question. So we're going to talk about it. What is a calcium score? What does it tell us about our health? And what can we do about an elevated score? So a calcium scan is a CAT scan, and it basically just shows calcium score and calcium buildup in the arteries. And it's a better way of assessing risk than cholesterol alone, or just looking at blood pressure and blood sugar. And what we're actually doing is putting you in a scanner and then looking at your heart, basically, and looking at the calcium that's in the heart. And you could see here, these are 4 different, I think we're going to zoom in here as to what we're exactly looking at. These are 4 different examples of the heart. We're taking one cross-section of the heart, realize there's 100 cross-sections we're looking at. And when the score is 0, there, you could see the piping is completely clear. But, as with a calcium score can go up, with more age and more damage. And even as the score progresses, you can see that the artery, the main artery, the aorta, can even get calcified. And like I was saying before, that calcium score has a volume score and a density score, meaning how white is this area and how big is that area. It's two different measurements that we sort of put together to composite and give you a score. And you can see here, like the arrows pointing to the white area, that's the calcium in your spine. And so we're looking basically for those white areas that you see pointed by the arrow, and we use computer to estimate the score for us. A lot of the scoring is now done completely computerized. You could see here in this bottom right hand corner, look how calcified that aorta is. So not only are their coronaries calcified, but their arteries are hardened too. So this person's blood pressure would probably be very, very high because those pipes are not as flexible. Commonly seen with age and particularly with smoking and diabetes. So what will you see on that calcium score? You have that sort of soft plaque and that necrotic core. These can be reversed. We have documented reversal of these soft plaques and fibrous plaques. Once they get calcified, they're seen on calcium scans. So, and remember that calcium means it's usually an evolved plaque. It's not like this new plaque. It's been there likely for a long time. There are acute causes of calcified plaque, which I should say, like if you have Kawasaki's disease, which is like an autoimmune disease. So there's a pediatrician here in the audience. If you have Kawasaki's disease and you get a coronary dissection or coronary inflammation, right? It's an autoimmune vasculitis that affects kids. So where's my resident not my resident, but my pediatrician here? She probably knows all about it. You can see in those patients, they can acutely develop some calcium, and that calcium will persist for a long time. Or maybe you had a coronary dissection in pregnancy. I've seen this persistent and acute calcification. That calcification will occur within months and will basically stay there for the rest of their lives, usually not progressing in the same way as we'd see with atherosclerosis. So a calcium scan is used to get the score, and the question I get is how much radiation is it? There is some radiation, and yes, you don't want radiation, so don't discount that. If you cannot get radiation, don't get it. But it's about 1 millisievert, which is like the maybe 2.5 long haul flights on a plane. So that's the amount of radiation in it. The CCTA has about 7 to 12 millisieverts. The newer scans, the newer machines, like there's maybe 10 or 20 of these in certain areas, they have a lot lower radiation. So I think the radiation issue will decrease over time. So things to know about a calcium score, just the calcium score is going to go up with age. The higher the score, there is a higher risk, right, of heart attack. And a 0 can score if you have no risk factors. I mean, the chances of you having a heart attack over the next 7 years is very low, unless you do the cocaine and the cadmium and go sleepless and do that. So unless in a high risk scenario, let's say you have a 0 score and you have type 2 diabetes diagnosis, the overall majority will get calcium within the first 3 to 5 years. So if you were to develop calcium, if you were to develop diabetes, like let's say today you got diabetes and your A1C is 7, right? You will develop calcium likely over the next 3 to 5 years. So just a thing to think about. So this is an important this is white men. So why that matters, the percentiles are different for women, who tend to get calcium at 10 years later than men, 5 to 10 years later than men. And different ethnicities get them at different ages. So, but I use white men just as a standard so you can sort of gauge. White men at 45, very few will actually have calcium, meaning like probably 75% will have none. And if you had a score of 36 at the age of 45 as a white man, that's like you're in the top 10%. You got to be careful. If you had a 0 score, it's not that you can't have a heart attack. It's, you're not in this extremely high risk group. So as you age, you can see that more and more people develop calcium. So, if you're 75 and you have a score of 52 or 50, well, that's actually a really good score. You have a lot less calcium than most of your peers. And you can see that, at the age 75, there are many people who have these, very high thousands level calcium scores. These are just like, giving you sort of an idea of the risk. So let's say, you're 50-year-old male, okay, and you had a 0 score. What's your 10-year risk of having a heart issue? It's 1.7%. You can see my cursor here. Well, if you had a score of 22, which is about an average score, well, that means your 10-year risk of having a heart attack is 4%, and you had a score of 110 at age 50, well, that's a 6% risk. So these scores, what they can do is sort of give you an idea of like, okay, how much should I be looking into my coronary disease? How aggressively should I be screening? Should I consider taking a baby aspirin? Should I consider medications or maybe a stress test, right? It's not like this doesn't confer good or bad. It's just like, how much should I look? The way I tell some people is, I have a sink right here in my office, and if I suspect the pipes are a little rusty, maybe I check in a little bit more frequently than I would if it was completely clear, right? So that's that's the nature of this test. So it's not like a good, bad, and you can see the biggest thing that confers risk is age, as we age. So it's the calcium score is a great predictor, but even more potent than predicting a calcium score is age. So a 0 score really and no risk factors means like the chance of you having a coronary event are very, very low. I would sell you life insurance. Like I would, because I think you're going to live for a very long time. If the score is high and you have risk factors, somebody said my score is in 1,000. Well, how many risk factors do you have if you got rid of the diabetes and you're active now because you feel good and you're, well, maybe your risk is like 10%. Well, this is what you can control. I mean, control what you can control. You're not going to be able to control your age, and the fact that the score is high. I think you could just do your best to mitigate the risk. This is an important study. This is like the study that I think sort of makes the point about statins, right? And I'm not a fan of statins from one side because they have a lot of side effects, insulin resistance, mitochondrial dysfunction, developing diabetes, muscle aches, etc., joint issues. But in terms of drugs that have been shown to lower all-cause mortality, and there is some question about that, so I won't say that doesn't come with some controversy. They're probably the most definitive in terms of the effect they have. They just have a lot of baggage. They cause a lot of problems. And I think the biggest problem with statins is that doctors just overuse drugs. So if you had a 0 score or you had a low score for a very long time, you'd have to take a drug for over a decade to appreciate even a percentage difference in outcomes. Where I think maybe, sort of the trust should, I think most times you'll win not trusting a doctor and asking them to explain themselves, and probably getting gaslit along the way. But, I think when your score is above 100 and particularly above 400, you can see it appears that in that subgroup, the statins have more of an effect. And so what does it tell me? It's just like antibiotics. Like, if somebody has the sniffles, I'm not rushing them to give them antibiotics. I think the antibiotic will cause more harm. They may have an allergy. They may get, C. diff. They may get issues, related to antibiotics. Some of them cause, joint issues and tendon issues. Some of them can cause autoimmune issues, right? So, so the thing is, but if you have sepsis, if you have a blood infection, if your heart rate's through the roof and your blood pressure is really low and you have a high fever and it's been going on for days, well, that person probably would benefit from antibiotics, right? So I don't really knock the drug so much. The drug has positives and negatives. I knock more my profession for not having the ability to discern maybe who is the best person to use this and who's not. So I think we should probably turn our ire more away from the drugs per se and just more to the doctors who maybe have, the 80% or so that I'd estimate overprescribe and underthink. So here's the key takeaways from the calcium score that I think you could appreciate. Higher score means higher risk of disease. A 0 score means a very low risk of disease. And, should you repeat it? I think in high risk scenarios with a 0 score, you may want to look at 3 to 5 years. Low risk scenarios, 5 to 7 years. And there's always an exception of, there's always special cases. I think this goes to what if you're not 0, and I'm going to sort of blast through this because I am coming on 6:30 and my wife will kill me. But you'll see, that the biggest thing here is, look, the calcium score does drive risk, but in your power is reducing the risk factors. If you're not exercising, exercise, right? If you can, right? Symptom-free. If you are, if you have diabetes, work with a metabolic health doc to reverse that or address that. Low-carb diets are really effective. Weight loss also helps. If you have metabolic syndrome, low-carb diets, calorie for calorie reverse that. Hypertension, low-carb diets address that. So I think it's in your power to do a lot, but you can't change age, and you certainly can't change calcium score. genetics and existing calcium, although maybe even that we can call into question. There's some case reports of calcium score reduction that I've looked at. I will tell you the majority of calcium score, 0 calcium scores that I've had to people who had a high score and it went to 0, or, when I looked at the images myself, and you guys all know that I'm a big believer in looking at the images when and if available, if the institutions will send it to me, because we beg for them pretty much. But when they send it to me and when I look at it, the only time I've seen a score that actually, when I saw a score that went to 0 and we confirmed with the images, the score was actually just inaccurate. The whole heart was not even in the field of the calcium score. So I am very wary. I've asked people who've had 0, like converted to 0, if they could send me their images. I've asked people who've had carotid plaques go from completely occlusive to non-existing. I've asked them to send me images. I haven't really followed up, but nobody's really sent it to me. And all the ones I've looked in my own eyes that went to 0 from a high score were an error. So, which is maybe 2 or 3. Not saying it can't happen. I've had 10 or more, maybe 15 patients with stable scores over a long time. And usually, and I don't know, I think they're active people who typically take aspirin, typically are very low carb, and most of them are either on fish oil or Vascepa, and some of them take Zetia, some of them take statins, depending on how they feel and what they want to do. But that's just in my clinic, the 10 or 15 that we have. And when I say my clinic, I have to give a shout out to Laura Buchanan, who's also in our clinic, and she's just the most amazing doctor to also work with. It's been an absolute pleasure to work with her on research projects and presentations. In fact, most of this presentation is from Laura. She's on the board with me with the SMHP. So, there's a lot of different things that have decreased score, decreased risk of having a heart attack, high-intensity interval training, exercise, aspirin, prescription grade fish oil, some drugs. There's some things that have maybe have an effect on plaques, calcium channel blockers in the setting of hypertension. Nattokinase is shown to reduce carotid plaque. Vitamin K2 has been shown to halt plaque progression. But it's unclear. These are more like theoretic. They're theoretical. I'd probably take them, but I would caveat that we've not done an outcome study with these. And the reason why we have outcomes of the top 4 is because drug companies know they can make billions. So it's kind of a setup. But I like Vascepa because most people don't eat enough fish, and it's basically purified EPA, and it's been shown to reduce soft plaques and serial CCTAs. I like baby aspirin and high CACs. In general, it comes with a bleeding risk. So people are like, well, should I take aspirin? Well, if you're an MMA fighter who also does horseback while fencing, that would be a person that maybe I would second guess using baby aspirin in, right? But otherwise, if the score is generally above 100 or edging towards 100, we would lean into aspirin. I'm gonna skip over these. These are all in the CAC and coronary artery disease lecture that's right in the app. So these are all there. We've dissected all the data. We're going to make a nice chart of all the data that exists. All the drugs that have reduced plaques, we have evaluated. We've evaluated the data of that plaque reduction. Anything that's been shown to reduce risk in high CAC, we've evaluated. We've dug in, guys, to get you the best info that we can. we dug into vitamin K, we dug into nattokinase, calcium channel blockers, we dug into it all. So we're just trying to get you guys the best info. And we just covered on those the effects on the plaques. We didn't really cover the side effects. So that's like a discussion, you can have with your doctor, or if you want a legit medical team, shout out to Toward Health. But basically, if you're looking at what you can do, yeah, you can attack LDL with cholesterol-lowering drugs, and there's other drugs, that we'll be adding to that, like colchicine and others. But and bempedoic acid, which is a very interesting drug. But bottom line, what can you do? I mean, lifestyle matters most. Look at lifestyle on the top there, right? So lifestyle, which is, we know we can improve, diabetes, metabolic syndrome, hypertension, obesity, smoking, and activity, which is about as much as family history. So those you can do, those you can do. So it's not one or the other with drugs and supplements and all that, but, anyway, look, bottom line here, what you can take away, and I'm going to spend 2 minutes on questions if there are any more. If you got a calcium score of 0 and you're low risk, no risk factors, you may want to get one in 5 to 7 years. If you have high risk, right, you may want to consider getting it every 3 to 5 years. I think if you have a family history, strong family history, you should consider it at a younger age. My grandfather died in his 40s, so I got it starting at age 32. So, and I've gotten every 5 years since, on a low carb diet with LDLs that have fluctuated from 80 to 220, and yet it's remained 0 for 10 years. So that's my story. That's not your story. Hopefully this was helpful. Give me a thumbs up if this was helpful. Give me a heart. How many people? Well, I only lost 10 people, so that's not bad for a Tuesday night. That's not bad. Look, if you are part of our practice or part of the app, things are changing coming up. Okay, we are going to have health coaches available to you basically every day. We're going to have 30-minute sessions, Monday, Wednesday, and Thursday. Our Tuesday event is going to change a little bit. So if you needed support, it's right there in the app. You can just come right in. Tuesdays are going to change. It's not going to become as regular, but the physicians are going to try to hold our lectures at pretty much, sometime Tuesday at 5:30 periodically. So we're going to make daily support groups with the health coaches, and then we're going to have, lectures like this. This month is a little bit different. Laura was going to do it on the Tuesday the 18th. Instead, because she's talking about fasting, we're going to combine that into week 3 of our fasting course. So I think you have to the end of the day to sign up. So sign up to get access to that. And let's see, anonymous attendee, do you see a difference between low carb and carnivore when it comes to heart health? I don't see too much of a difference. I got to be honest. I've seen some carnivores really kill it. I've seen keto people kill it. Low carb people kill it. And the reason why is most people in our society have metabolic syndrome. So all of those will work, lower the blood pressure, lower the sugar, lower the weight. So carnivore is a good way to go. I do carnivore for big months at a time. So I think it's a, relatively healthy diet, particularly for those with diabetes. I think it's helpful. There you go. That's a nice testosterone boost, vitality boost. All right, guys, I gotta head out. So we'll see you all in a bit. Thanks for staying with me, and I hope you guys enjoy this stuff. I really do. And we're gonna try to keep, keeping the bar high, bringing more. This year, we're gonna have a food addiction webinar. It's gonna be amazing. It'll be in April. We're gonna have an exercise for metabolic health webinar. You know, each of these are going to have like 8 lectures or so on all-day event, and we'll you know, of course, bring that back to the app. So we got a lot of stuff we're planning this year, and hopefully you guys stick around. All right, guys. Oh wait, let me just put in the link. I'm going to put it here, Toward Health. I think it's right here /courses. I think that's the link. And then you go there and you go to the you go to sign up for the course, the fasting course. All right, y'all.